how does the clinician who's listening to this, how do you manage this? Someone comes in to see you for the first time, are you just ordering LDL cholesterol and non-HDL cholesterol, which are currently in the guidelines, and there's evidence for treating those and reducing events, and you treat those, and then later on you go and order ApoB? Or do you just skip all of that, order ApoB at the beginning, and just get ApoB to goal, and in doing so, non-HDL cholesterol and LDL cholesterol will follow suit?
Well, so remember I mentioned that 3 months ago, my entire practice now is clinical lipidology and preventive cardiology. So all of my patients have been referred or have self-referred. And I think there's a different relationship when someone comes in just to pay attention to their cardiometabolic and lipid status than someone who's coming in with a sore elbow and you say, oh, gee, I see you have a pack of cigarettes in your pocket. Rather than talking about your elbow today, can we talk about your cardiovascular risk? So two completely different contexts when you're talking about primary care versus a lipidology practice. In my practice, every time I see somebody for the first time, I like to see a lipid panel and an ApoB done simultaneously. If they've never checked their LPA before, we'll also use that opportunity to check their lipoprotein (a). And if they're not on treatment, even better, because now I can learn about their underlying condition and understand a little bit more about whether or not they have a lipid syndrome, because I'm always wearing my lipidology hat. And so,
but does that get a little harder to pick up when you start to, do things get masked when you start to see, when you're looking at someone who's already on lipid lowering therapy?
Yeah, it kind of does, because the lipid syndromes are characterized by which lipoprotein is elevated. And if you're taking medicine to treat that already, you've already addressed part of that problem. So you may not identify the syndrome if you don't have, their pre-treatment levels.
Yeah, I guess that would be a nice scenario would be to have a patient come that has all of their historical blood tests before starting.
It definitely makes I learn more. The more data, the more I learn. And so in my patients who, so the real time when I do want to check the ApoB is first evaluation, new treatment and response to therapy to make sure that both have responded adequately. And anytime I change treatment, once I've established that person now has concordant results, then I don't think I need to keep ordering a separate test. If I got to design things the way I wanted, I would just add, I wish an ApoB were part of a lipid panel. It's, the current lipid panel is total cholesterol, triglyceride level, HDL cholesterol, an LDL cholesterol calculation, and sometimes they'll report a non-HDL cholesterol, but you can do the math yourself too.
I understand that a large percentage of people who have this discordance between ApoB and LDL cholesterol and ApoB and non-HDL, which we haven't really unpacked, so we'll get there, are people with type 2 diabetes, high triglycerides. But I also understand from a paper that you referred me to yesterday that it is possible for someone who presents as healthy, lean, metabolically healthy to also have discordance where they might get their LDL cholesterol measured, it looks good, but their ApoB is sky high.
Yeah, so Anne-Marie Navarre is the lead author on this fantastic ApoB paper that was published a month or two before our consensus statement was published. Kevin Mackey sent me the paper when it first came out, and I have to say that when it came, I was so engrossed in doing the finishing touches on our paper. My response was, I couldn't read it at the time, and I just wasn't ready to crack it open. But I think we all were inspired by the same thing, which is, decades of Alan Snyderman teaching us about the importance of a metric that demonstrates the number of particles as opposed to the lipid content of those particles. They looked at a lot of the same literature, and they drew a lot of the same conclusions themselves. And they made a bigger point of this concept of discordance in people who are more metabolically healthy or less metabolically sick, that discordance phenomena can occur. In our paper, we didn't break it down that way. We didn't look at that particular evidence, but I know that exists, and I know And they reported it beautifully that while it's probably more common in people who have insulin resistance and hypertriglyceridemia and visceral adiposity and diabetes, it's not exclusive to that population. So I do like to see ApoB levels and lipid profiles on all my patients whenever possible because of that phenomenon.
And for someone who's listening, who's thinking, oh, I thought non-HDL cholesterol was very similar to ApoB, or at least a better predictor than LDL cholesterol, how would you explain the difference between LDL cholesterol, non-HDL cholesterol, and ApoB in terms of predicting risk?
Non-HDL cholesterol is a fantastic tool. It works a great deal of the time, but you can get non-HDL cholesterol and ApoB discordance as well. And when that occurs, I think the evidence more strongly supports using ApoB, but it's not a slam dunk. I think there's some evidence that would suggest that non-HDL cholesterol has some advantages over ApoB. I come down on the side of if there's discordance between the two of them, I tend to prefer ApoB. And I hate to introduce, yet another possible, scenario that's equally confounding, which is LDL particle ApoB discordance. And that drives me crazy because some of our patients end up doing NMR and ion mobility testing for LDL particle number. And I think I have this like fancy high-tech test, looking at LDL particle number, and that's got to be the best test. But you'll still see ApoB discordance with those individuals.
Where there's presumably more VLDLs and IDLs or less of those, and somehow that's affecting ApoB.
Yeah. And I don't know actually the reason for that. I mean, we could probably work through it, but I'm told by some of my colleagues who are deep in lab science expertise that in that circumstance, the technologies that we use that look so valuable, NMR and ion mobility, actually are not as reliable in that circumstance, and that ApoB actually outperforms LDL particle in that circumstance. I can't cite the studies. This was based upon internal conversations with some of the colleagues I trust very highly.
Okay, so if someone's not seeing a lipid specialist, doesn't have a significant history of cardiovascular disease, is just doing a regular yearly blood panel, ApoB would be a nice to have, but non-HDL cholesterol is going to be pretty good at that stage.
I think it is pretty good. It's quite good. I'll rephrase that. It's quite good. The National Lipid Association wrote a paper in 2014 actually suggesting that non-HDL cholesterol be the primary target of therapy and that LDL cholesterol should be the secondary target of therapy, meaning once you fix the non-HDL cholesterol, sure, look at the LDL cholesterol then, and in the number of people who will need to do anything different at that point is so small that you're probably not making a difference. And that's why prioritizing non-HDL cholesterol.
It's 2025 and I have made the decision to join Function Health to help monitor and optimize my health. And honestly, after getting set up, I am wondering what took me so long. Function makes it extremely easy to track important biometric information over a lifetime, information that you can use in real time to make important health decisions. Function gives you over 100 lab tests covering your entire body every year. Heart, hormones, liver, kidneys, thyroid, metabolic health, heavy metals, autoimmunity, nutrients, and more. 5 times more testing than your typical physical for $499 a year. A lot cheaper than if you were to order all of these tests individually. That's if you can order them. Take ApoB and Lp(a), for example, 2 very important tests for determining your risk of having a heart attack or stroke. Yet, as outlined in multiple episodes on this show by Dr. Thomas Dayspring, they can be incredibly difficult to order with your local doctor. Using Function is very straightforward. You join and then visit one of their 2,000 US lab locations. I went to one here in LA where I live. It's very easy, and boom, your results are tracked over time in one secure place. No shady upselling, no gimmicks, just your results beautifully presented and science-based insights from doctors to help you optimize your health. Skip the 400,000 person waitlist today at functionhealth.com/Simon Hill and join me on the path to nerd level health optimization. That's functionhealth.com/Simon Hill. That's good for the section of the population that are not sort of at a intermediate or moderate high risk of cardiovascular disease, given that I think ApoB tests are becoming more accessible, but they still can come with a little bit of a cost, which creates an accessibility issue for certain people.
Yeah, they sometimes get rejected. I'll get a message from a patient saying, "Hey, that test that you did 6 months ago, it won't be 6 days ago. It'll be 6 months later." They get a notice that test that I ordered on them 6 months ago was rejected, was denied by the insurer, and they usually refer to it as an experimental test. So one of the things that we felt was important in writing this consensus statement was to make it clear, this is not an experimental test. This is as close to done science as we can get. This is a highly validated, reproducible, high quality test that demonstrates residual atherosclerotic cardiovascular risk due to lipid and lipoprotein abnormalities. So we made that pretty clear in the consensus statement. And I hope clinicians around the country don't have to write appeals for authorization for tests as much as they used to. But if they need to, they can use our paper as a reference since it comes from the National Lipid Association.
What do you think is required for ApoB to take the next step and be included in kind of AHA guidelines as a treatment target?
The AHA, ACC, multi-society cholesterol treatment guideline writing teams are complicated. And, the level of evidence has to be reviewed by committee. There's a lot of people have to all agree on the same thing. And the standards have to be set. I don't know the answer to that question, but I think that there is, the pendulum is shifting that way. Based upon the level of evidence and conversations I've had with colleagues. But ultimately, I think that's going to remains to be seen.
Yeah, I was going to ask you that. What's the feedback been like from colleagues since you've published this paper? Do you feel any resistance towards this kind of recommendation to start taking ApoB seriously, or is it pretty much universally being accepted as the better predictor for atherosclerotic cardiovascular disease than non-HDL cholesterol and LDL cholesterol, and therefore wise to order it when accessible for a patient?
I haven't gotten a ton of feedback about the paper. All of it's been positive. No one has said to me, "I completely disagree with you. ApoB is useless." No one has said that. So I'll take the silence as it's not silence. I got plenty of feedback that said, "Great paper. You guys did a great job. I really appreciate you creating these tables and the figures. It's been very helpful. I'm so glad to have this resource." But I haven't gotten any of the negative feedback. So I think I'll take that as people agree.
And within your group that was writing the paper, was there pretty much universal agreement on the things that you included in the report?
Yeah. I mean, I hate to say that because did you really do something good if everybody's in agreement? Like you need to introduce, you like to have people who have a disagreement and bring a different, approach to this. And we had plenty of conversations and plenty of opportunities to add more information. And everybody was like, "Yeah, this is great. Let's just tidy up the wording. Let's make sure that we say this the way we want to say this." And this was yes, it was a handpicked group, but it wasn't a handpicked group of people who are on Team ApoB. This was a handpicked group of people who have contributed to the scientific literature, to the lipidology literature, who are willing to say, "Hey, what you're saying is stupid." And I'm smiling because I'm just thinking of some conversations we had while we were making it with some of my colleagues who were willing to say, "Hey, what you just said there was pretty stupid. Let's fix that." And they didn't say it those ways. Everybody was collegial and nice to each other. But there was no clash. There was widespread agreement that, yeah, ApoB is the thing.
I've seen and you get this with anything. If I've seen any resistance online, I've seen people kind of accuse big pharma of just finding another way to prescribe more lipid lowering therapy. What would you say to the person that thinks this is the pharmaceutical industry just trying to influence clinicians so that they're prescribing more drugs?
Well, I can tell you that our analysis also pointed out the times when you're going to prescribe less drug when you have high LDL cholesterol and low ApoB. And even though we didn't do a quantitative numerical analysis of the number of individuals who are affected by discordance, when you eyeball the charts, what you're left with is a conclusion that the number of people on drug is going to be roughly the same, because you're going to treat more people more aggressively at the lower end where there's discordance and high ApoB and low LDL cholesterol who need more intensification of therapy. But there's going to be some people who their LDL cholesterol may be a certain thing, but their ApoB is quite low and you're done. And at the higher end, people with higher levels of LDL cholesterol but low ApoB don't necessarily need pharmacotherapy, assuming that they don't have significant atherosclerosis. I would just
there
want
are
to point
cases
out
where you can defer.
I think so.
Treatment.
Yeah, just like you would with LDL cholesterol in people at low risk. You would defer treatment if their ApoB is low and they are at low risk, meaning they don't have evidence of significant atherosclerosis. Remember, if there's athero present, significant enough athero present, regardless of whatever measured variables you're looking at, we use LDL lowering therapy because LDL lowering therapy reduces the risk for bad outcomes in people with significant atherosclerosis.
Right, but if you're someone that doesn't have atherosclerosis, has high LDL cholesterol, and physician recommends to lower that with a lipid lowering therapy, that's an interesting context to say, hey, I might check my ApoB before I start this prescription.
Totally agree. And when making that kind of recommendation, someone who looks like they're at low risk, has no, we didn't talk about how to identify whether somebody has atherosclerosis, but there are different tools for that. You don't see any signs of atherosclerosis, then the response when someone to the clinician who says you should treat this anyway, the response to that should be, do I have to treat it now? Can I delay that? I know I'm just trying to minimize my exposure to medicine. All things sort of point to me being at low short-term risk, and maybe my 50-year risk is significant, but maybe as I get closer, maybe can we wait a decade? Can we wait 20 years? Can we monitor my progress along the way and change our plan if we start to see something changing?
This episode is proudly brought to you by 38 Terra. Try 38 Terra's DMN prebiotic, the science-based daily multivitamin for your gut microbes, a simple and delicious way to take your gut health to the next level. Now back in stock in new and improved packaging for customers living in the United States, Australia, and New Zealand. Get 10% off your DMN at 38terra.com using the code THEPROOF. That's 38terra.com and use the coupon code THEPROOF for 10% off.